Dengue. Your lung is not safe. Dr. Jalal Mohsin Uddin. D.T.C.D, FCPS, Pulmonology. Assistant Professor. National Institute of Diseases of Chest and Hospital. Do not allow Aedes to bite you. Introduction. The prevalence of dengue virus infection has increased dramatically in recent decades. The disease is now endemic in 100 countries worldwide. The global resurgence of dengue is thought to be due to the failure to control Aedes populations for 1. Uncontrolled urbanization. 2. Population growth. 3. Climate change, and 4. Increasing numbers of international travelers. Lung disease is not common among general dengue patients. The symptoms are generally mild and affect mainly the upper airway. However, it is common and more prominent among severe dengue or fatal dengue cases. So, the problem can be various manifested and can lead to death. The practitioner has to recognize the lung disease among the patient with dengue for proper management. Signs and symptoms. Many people experience no signs or symptoms of a dengue infection. When symptoms do occur, they may be mistaken for other illnesses, such as the flu, and usually begin 4 to 10 days after you are bitten by an infected mosquito. Dengue fever causes a high fever, 104 F, 40 C, and any of the following signs and symptoms: 1. Headache, 2. Muscle, 3. Bone or joint pain, 4. Nausea, 5. Vomiting, 6. Pain behind the eyes, 7. Rash. Following respiratory symptoms may appear along with above-mentioned features: 1. Cough. 2. Coughing out of blood. 3. Shortness of breath. 4. Chest pain. Clinical presentations of lung involvement. Thoracic manifestations such as 1. Pleural effusion. 2. Interstitial edema. 3. Pneumonia. 4. Focal or diffuse zones of alveolar congestion. 5. Pulmonary hemorrhage and hemoptysis. 6. Dengue hemorrhagic fever, DHF, can result in acute respiratory distress syndrome. 7. Dengue shock syndrome, DSS, is reported to be the third leading cause of Aedes in dengue endemic area. Pathogenesis of lung diseases in dengue. First, thrombocytopenia can directly cause spontaneous bleeding in any organs including to lung in dengue patients. Diffuse alveolar hemorrhage is rare, and is typically related to severe, often fatal forms of the disease. Hemoptysis has been reported in 1.4% of dengue infections. Second, plasma leakage during dengue infection can also be the causes of lung problem. This process is approved to be a consequence of dengue immunopathology. It may result pleural effusion, most frequently, acute respiratory distress syndrome. Third, superimposed lung infections in dengue patients are also reported. Experiences of various countries. In a recent study, the magnitude of pulmonary pathology in fatal cases of dengue hemorrhagic fever in Thailand, and found that almost all death cases had lung pathology. A similar observation was also reported from Cuba. Guzman et al. Noted that lung pathology could be seen in all fatal dengue cases in their study, and the virus could be identified in lung of the death cases. Another report from Venezuela also showed the same finding, that all dengue death cases had lung disease. All these cases showed severe lung disease like diffuse alveolar damage, non-cardiogenic pulmonary edema, thromboembolism, bronchopneumonia, pneumonitis, interalveolar hemorrhage. They also reported that respiratory failure was the cause of death in 2/3 of the studied fatal cases. About 38.6% of severe dengue cases in this report presented pleural effusion due to plasma leakage. Histopathological analysis of lung sections from fatal dengue cases, A, B, C, stained with hematoxylin and eosin, showed pulmonary alterations, including alveolar septal thickening, hyaline membrane formation, hemorrhage, He, edema, E, and the presence of type 2 pneumocytes, C. DOI 10.1371/journal.bone.00961313.go05. Evaluation and management of lung pathology. 1. Pulmonary hemorrhage. This can be early detected by lung CT scan. The pattern is usually diffuse alveolar hemorrhage. In immunocompetent host, dengue must be a differential diagnosis in any cases with problem of diffuse alveolar hemorrhage. The other differential diagnoses are influenza A, H1N1, leptospirosis, malaria, and Staphylococcus aureus infection. It should be noted that the combination of dengue and other concurrent tropical infection is also possible to cause pulmonary hemorrhage, such as concurrent dengue and leptospirosis-induced pulmonary hemorrhage. The case can be serious and fatal. The management is usually supportive and symptomatic. 2. Pleural effusion. Pleural effusion is the sign of dengue hemorrhagic fever and dengue shock. It is noted that the ultrasonography can help early diagnosis of effusion and can help the physician in charge to plan for management of pending severe clinical features of dengue. To manage the patients, conservative management can be useful in cases with small effusion. However, in cases with large amount of effusion, the intercostal drainage placement is indicated. In some severe case, a more complex complication, hemothorax can be observed, and the use of intercostal drainage placement is useful for management. The fluid replacement therapy and balancing of body fluid is required, which can be based on standard guideline for management of any dengue cases. 3. Pneumonia. In general, dengue does not cause pneumonia. Finding of pneumonia in dengue case is possible and usually implies superimposed bacterial infection. Staphylococcus aureus and melioidosis are the two common problematic pneumonias that can superimpose dengue infection. To manage the problem, identification of the pathogen and assignment of proper antibiotic is required. 4. Pulmonary edema. The pathophysiology is the same as the case of pleural effusion. Disturbance of colloid oncotic pressure is believed to be the main cause of pulmonary edema. Sometimes, the problem can also be seen in concordant with other dengue systemic problems such as dengue myocarditis, plasma leakage. It should also be noted that pulmonary edema can be sometimes iatrogenic. The case of pulmonary edema after platelet transfusion or excessive fluid therapy in dengue patient is the good example. The acute pulmonary edemas in those cases are usually observed in the convalescence phase. 5. Respiratory distress syndrome. Respiratory distress syndrome is the most serious lung disease in dengue, and this can result in respiratory failure. Sometimes, the problem can also be seen in concordant with other dengue systemic problems such as acute pancreatitis and myocarditis. Aggressive management will be needed and can be helpful in increasing survival. The fluid replacement therapy, balancing of body fluid as well as ventilation management is required. Chest imaging pattern in dengue. The most commonly observed chest imaging finding in dengue is pleural effusion, which is often bilateral. When unilateral, it usually occurs on the right. Parenchymal abnormalities, including ground glass opacities and consolidations, are less common, have no specific distribution pattern, and can be accompanied by interlobular septal thickening and nodules, representing edema or pulmonary hemorrhage. In A and B, a 37-year-old woman with severe dengue and pulmonary hemorrhage. Axial CT scan, A, and coronal reconstruction, B, showing bilateral multifocal areas of consolidation and ground glass opacity. In C and D, a 51-year-old woman with severe dengue and findings of pulmonary edema. Axial CT scans of the upper and lower lobes, C and D, respectively, showing bilateral peribronchovascular and interlobular septal thickening, together with multifocal areas of mild consolidation and ground glass opacity in both lungs. Note also the bilateral pleural effusion. A 78-year-old man with a confirmed diagnosis of dengue. CT images, A, B, show moderate and diffuse ground glass opacities with no specific distribution in the lungs. DOI 10.1000.journal.bone.00963313.G003. A 30-year-old woman with a confirmed diagnosis of dengue and respiratory failure requiring non-invasive ventilation. CT image acquired 6 days after the onset of clinical symptoms. A, shows interlobular septal thickening, mild ill-defined ground glass opacities, and peribronchovascular interstitial thickening. Bilateral pleural effusion is also present. Complete resolution of the parenchymal abnormalities was observed on the CT images, B, obtained 7 days later. DOI 10.1371/journal.bone.00963313.G004. In a study review of the CT findings of 9 patients with severe dengue confirmed by serology. The most common CT findings were multifocal ground glass opacities, which were seen in 8 patients, 88.9%. A predominance of central, perihilar, lung involvement was observed in 4 patients, 44.4%. 4 patients, 44.4%, also had areas of consolidation. The consolidations were accompanied by ground glass opacities in 3 patients, 33.3%. Consolidations only were observed in 1, 11.1%. A crazy paving pattern and smooth interlobular septal thickening were observed in 1 patient, 11.1% each. Bilateral pleural effusion was observed in 5 patients, 55.6%. In all of the patients, the abnormalities were bilateral and diffuse. Radiological differential diagnosis. Drawing clinical and radiological distinctions between dengue and other infections that cause diffuse pulmonary hemorrhage may be challenging. In immunocompetent patients, the most important infectious diseases for differential diagnosis include influenza A, H1N1, leptospirosis, malaria, and hantavirus pulmonary syndrome. Take-home message. Lung abnormalities are common and more prominent among severe dengue or fatal dengue cases, and imaging findings reflect increased vascular permeability. Dengue should be considered in the differential diagnosis of patients with fever, hemoptysis, and diffuse pulmonary infiltration. Thank you all. Dengue. Your lung is not safe.